to speak to you. It's always a pleasure to talk about, what I do at Care First. So I may have met some of you in person when I attended another one of your seminars, I think several months ago down on your campus. But I guess I was approached to kind of speak about, I guess a day in the life of a pharmacist, or what do I do. So I thought it'd be best for me to tell you about one of the programs that I oversee, and I'll kind of run through the program and how we operate, and then provide commentary on why we have the program and what I do as far as direct responsibilities for this. So I joined Care First about 2.5 years ago now. My actual title is Program Director for Comprehensive Medication Reviews, which is the program I'm going to speak to you about, although that, I've morphed that role a little bit, and I have oversight of several other clinical pharmacy programs we have, but I do have, direct and 100% responsibility for this program. So kind of wanted to just give you a little bit of background. Let's see how I can advance my slides here. So I have an agenda set up. Before I even can really talk about the comprehensive medication review, I think it's helpful to talk about what's going on healthcare landscape industry-wise, which then puts into perspective what Care First is doing with our what we call our TCCI, which is our total cost and care improvement, and our patient-centered medical home models, which leads very nicely into our comprehensive medication review. So it's helpful to kind of have that background to understand why we even have a comprehensive medication review program at Care First. So just really briefly, if we look at kind of what's going on out there in the healthcare landscape today, we know that there's a lot of shifting demographics among our population. It's estimated nearly 1 in 2 adults have at least one chronic condition, and we know that chronic conditions really drive a high percentage of our healthcare cost. It's estimated in 2030, 1 in 5 Americans will be over 65 years of age, and thus that increases the need for chronic care, right? So the older you are, the more chronic conditions, and then thus, cost of care goes up as well. The other thing that's happening within our demographics is, people are living a lot longer today, which, we know is due to advances in the understanding of causes of diseases as well as improved treatments. But that also means then more people are living with chronic diseases. So among the chronic diseases, it's estimated that about 62% of the cost is concentrated within 12% of the population. And that's very, very true. We see across a lot of statistics that you have a smaller portion of populations that drive a higher percentage of cost or utilization, whatever you're looking at. And then according to Care First statistics, one hospital admission can cost on average upwards of $20,000. So it's a significant, cost, and the better we can control these chronic conditions, hopefully we can reduce the incidence of these hospital admissions, which are high drivers of cost. But what we're also seeing within the landscape is that pharmacy is becoming more and more in the headlines, and I'm sure you all are aware of it, as regarding spend and the trajectory that we're taking in the industry with pharmacy, in particular to the innovation of products, and thus the cost associated with that innovation. So at Care First, when we looked at our numbers and we break it down by different types of care, so we look at what does, pharmacy cost our members, what does primary care or PCPs cost, what do inpatient admissions, specialist care, and we look at it across all those different spectrums. Pharmacy in 2015 has risen to be the largest contributor to overall healthcare costs for our members. And it's really in a small portion of the population. So again, similar to the chronic disease and what's happening with general healthcare costs in the population, it's same in pharmacy, where we have a small portion, about 3% of our population is driving more than 30% of the cost. But then also pharmacy overall is the #1 cost driver for our members. So it's important to recognize that because we have to do things to make sure that pharmacy utilization is appropriate and that we can help kind of slow that trajectory of increase that we're seeing. And I kind of already mentioned, but we're expecting to see pharmacy drug trend reach double-digit levels, and it's primarily due to specialty pharmacy. So a lot of those products you're seeing coming to the market for the rare conditions that come at very, very high dollar amounts. So they touch a small portion of our population, but they're costing a significant amount. So moving on about some other challenges. So it said that, you know, we have a fragmented healthcare system, and fragmentation, you know, comes with misalignment of incentives. There's lack of coordination among whether it be PCPs and specialists, or lack of coordination between hospitals and outpatient, inpatient, outpatient care. And all this fragmentation in our healthcare system really adversely impacts quality, cost, and outcomes. So we believe that a lot of these challenges that we face can be overcome through greater integration of healthcare delivery. So at Care First, we took an approach. We saw where this kind of trajectory was going as far as spend and utilization, and we wanted to try to control that growth of increase, right? So we know it's always going to go up because of inflation, but can we bend, quote unquote, bend that cost curve? And rather it going up, you know, exponentially, could we flatten that curve and get that cost increase to go slower? So Care First, back in 2011, we created a program called the Total Cost and Care Improvement, or we name it TCCI, that really was trying to meet every member where they are in the continuum of care. So if you think about it, if you can capture patients when they're in the lower end of the spectrum in their care, which means it's more in a chronic disease management or wellness state before their diseases progress, that involves more care, hospitalizations, increased costs. If we can keep them on that lower end of the spectrum, we can help control costs and provide better quality of care. So with the core of our TCCI program, we created our patient-centered medical home, or our PCMH. And we wanted to really make that PCP a quarterback of that care. So that PCP would be responsible for the patients that are under their care. But we felt that since we were going to make our PCPs accountable for 100% of the cost associated with patients in their care, we wanted to provide them with an infrastructure surrounding that care that they could then have positive outcomes. So they could, you know, increase the quality of care that they provide. They can reduce the overall cost of care. And that's where we have, I'll go to the next slide. I'll go to the next slide. So this is where we have 18 supporting programs as part of our TCCI overarching program. So TCCI is kind of the umbrella term. I mentioned PCMH, this is its core. And you can see we have, over the past 6-ish years that PCMH, TCCI have been in development, created 18 supporting programs. And again, these programs really are just there to support the PCP to better manage their patients. So to talk about pharmacy, if you kind of look on the right-hand side towards the bottom, we have 2 pharmacy-specific programs because, again, pharmacy, you know, is an important factor in treating our patients. And comprehensive medication review, which I put the red box around, is one of these 18 supporting programs that I oversee, and I'm going to go through in a little bit more details of what that program looks like. So looking at how our CMR, comprehensive medication review, fits into the overarching program, we know that, you know, drugs, medications are really important, if not the single most important tool in treating diseases and chronic conditions. There's multiple, you know, elements within our TCCI program. We have another pharmacy coordination program, but this comprehensive medication program is really serving to identify members who are in the most in need of an in-depth review from a pharmacist. We are closely integrated with other programs such as our nurse care management programs, and I'll talk a little bit about that when we look at the program, to identify members who are the highest risk for medication-related issues. And really the purpose is to have that in-depth review from a pharmacist and answer the questions of not only what is the member taking, so it's not just about doing a reconciliation. Anyone can do a reconciliation, but once that reconciliation is complete, we really want to know what are the correct medications, or what medications should that member be on that fits their clinical profile. And again, we're just hoping that we can help control a lot of the cost or improve outcomes through appropriate medication management. So the next couple of slides, I'm going to go through the specific CMR program, and here's kind of where I'll try to talk a little bit more about what I do in my day-to-day role with oversight of this program. So I'll go through kind of how we identify referrals, the process, what kind of communications we do among our members and prescribers, what do we look for as far as how do we know if it's a valuable program or a valuable comprehensive medication review, the importance of data integration, and then some reporting aspects. So at a really high level, so I'm kind of taking you at like 20,000 feet above the program of what it looks like, not to really get into the specifics, but our comprehensive medication review program relies on referrals from our care management teams. So that's why I say it's closely integrated with our other programs. So we have several nurse case management programs. We have case managers who are nurses that specialize in certain disease states that work with a lot of our members who are going through transitions of care. So whether it's from an inpatient admission to home or to another facility, and there's acute needs that need to be addressed for those members. We have a team of nurses that do that. We also have what we call chronic care coordination nurses for our members that are identified with chronic conditions. They work with them and their PCPs, so it's a very close-knit relationship between the nurse, the PCP, and the member, and they enter kind of nurse care plans for anywhere from 6 to 9 months to try to help control their chronic diseases. So all of these nurses are working with our members on a daily basis. And we established referral criteria for these nurses. If they identify a member, and I'll go through the criteria in the next slide, that meet any of those criteria, we ask that they refer them into our program. Now, within our PCMH program, because our members and nurses and PCPs are working very closely together, we ask that we get PCP approval for some of the referrals. And it just has to do, we found that if the PCP had buy-in to the program and was aware that we were making the referral, it really just helps all of your processes downstream. So when that pharmacist identifies medication recommendations and they want to pick up the phone and talk to them, talk to the prescriber, or we send that prescriber a fax. If that PCP has knowledge and agrees to that review, they're more apt to engage with our pharmacist. They know that the referrals are occurring. They're expecting recommendations. So we just see greater downstream engagement and outcomes when from the very beginning we have that kind of buy-in from the PCP, versus when the PCP or a prescriber is not aware of the program, it's almost like either they're not getting notified of recommendations. They may not even know that a member's been referred for a review, and they're kind of caught off guard when recommendations come across, and they may not pay attention to them as much as when we kind of involve them in the referral process. So that's one of the things that we learned just by operating the program, that by talking to the PCPs, getting their approval, we have much better outcomes. So at Care First, we have our PBM, so our Pharmacy Benefits Manager is CVS Caremark. We have a dedicated team of pharmacists at CVS that do our comprehensive medication reviews for us. So we send all these referrals out to them. They will do a thorough review of the member. They have access to our electronic health record here at Care First, so they can view medical information, lab information. They can review the nurse's notes. And they would just work up that member and identify, the medication-related problems that I'm sure you guys are aware of. And then lastly, once the pharmacist has done the review, they may do outreach. So they're going to have a conversation with the member. So sometimes we'll engage the member for medication reconciliation. We will engage prescribers, and I'll go through kind of the various modes of engagement we have to talk about the recommendations that they've identified. So what makes a valuable referral? I think there's no surprises here if you read through this list. I won't go through everything, but we really felt that this program is comprehensive. So we wanted there to be multiple medications involved. We know the more prescribers that are involved in prescribing medications, the more complications there are. So one thing to keep in mind is CareFirst, we're a commercial plan, so we don't have Medicare. So I know you all may be very familiar with Medicare and MTM and medication therapy management type services, in which CMS dictates kind of your identification criteria for members into programs like this, such as number of drugs, number and types of chronic disease states, even pharmacy spend, maybe and then qualifying criteria. Since we're commercial, we're not bound by any of that. So we kind of just identified our own criteria in which we felt that our nurses should be paying attention to in the members that they're working with as criteria which would make good referrals. So one thing when I'm talking to our nurses, I always tell them that this criteria is not hard and fast rules. They don't have to meet, 1 and 2 and have 3 of the following. This is just supposed to serve as clinical guidance for them. We want them to use their clinical judgment and use this kind of criteria as guidance for members that would make a good referral. And we evaluate this on a regular basis. We always get feedback asking, am I making the right referral? Are there other things that we should be looking at in the members to make referrals into the program? So that's one of the things that I do. And my job is I look at the referrals that were coming in. I see, are the members meeting this criteria? Are there additional criteria we should be looking at? Could we identify criteria that would initiate, automatic referrals without attaining the PCP's approval? And we would vet that with our PCPs and say, if we identify a member who's a diabetic with an A1C greater than 8 and they're already on 2 medications, would you be okay with us submitting an automatic referral for a CMR? Or maybe the member has chronic kidney disease and has, a GFR of less than 50. So we're constantly looking for additional things that we could add to those lists or ways we could tweak this to make sure that you have the best outcomes. Because in order for you to have results from a program, you really have to make sure you're putting the right people into the program. And you'll really diminish the value as far as outcomes you get or perceived value from the physicians you're dealing with if you're not identifying the right people from the get-go. So that's one thing that we really try to work hard on, is making sure that we're finding the right members to put into our program. So what do the pharmacists do? Again, I think this is pretty straightforward for you all. They're looking to make sure the medication regimen is optimized, right? So is it up to date with guidelines? Is the patient meeting therapeutic goals? Is it safe and effective? Is the dosing optimized? Duplications, drug interactions, adherence, cost savings. So they run through the whole gamut of the things that they're looking for that is really typical to any pharmacist review. One thing that I already mentioned is that they do have access to our systems, which I think helps tremendously because they're able to have a wealth of information in addition to the pharmacy claims information, so they can really get a full picture of the members and patients in our program. So they're really able to identify high quality recommendations. So another thing that I do is just making sure, I periodically review the quality of the pharmacist recommendation. So CVS has their own QA team that they conduct for their pharmacists. They have an internal quality assurance team that will routinely review the pharmacist calls. So everything's done telephonically for our program. So they'll listen to calls, they'll do chart reviews on the pharmacist internally, just to make sure that, one, they're meeting the mandatory criteria, right? So if you're doing a phone call, you have to verify, certain HIPAA things. Are they following a certain script as far as who they are, why they're calling? like I mentioned, gaining the necessary HIPAA requirements. But additionally, they'll also do like a quality check. Is the pharmacist identifying the recommendations they should be? Are there any gaps in that? And then so I'll also periodically review the recommendations we get from the pharmacist and make sure that they're kind of meeting the standards that I would expect them to meet. So going over communication, so we have a different workflows in our program, and it really depends on the source of the referral. But we have a member workflow in which the pharmacist will do telephonic outreach for the medication reviews. So this is probably typical of most MTM type services. The pharmacist will, if they engage with the members, they do that complete medication reconciliation. They will do something very similar to what CMS Part D MTM programs do, and they'll mail the member a medication list and an action plan based on the items that they were discussed. So the member engagement is very typical to other programs. I think what's a little bit different in our program is how we approach our prescribers, because a large percentage of the referrals into our program are coming from our PCMH physicians, and our PCMH doctors are incentivized to help control the cost of care for the patients that fall under them. And we have all these supporting programs I mentioned. They're very used to working with our vendors, such as CVS, and they're looking for that extra support. So we have a couple different methods. We can have, if the pharmacist identifies recommendations that we consider like high clinical significance, so safety recommendations, significant cost savings, they will pick up the phone and try to reach that prescriber by telephone. So we have this telephonic outreach to discuss these kind of high significant, high clinical recommendations. And another thing they do as a supplement to that conversation is after they talk to the doctor, they will send what we call a post-conversation fax with a summary of the recommendations. If the pharmacist, as part of the review, kind of identifies what I would say kind of lower clinically significant recommendations, so things maybe just like a gap in care or an adherence issue, they may just send an email or a fax with that recommendation, and that would be in place of that telephone call. The other thing is that our pharmacists reach out to whoever the prescriber is for the recommendations that they identify. So that could be a specialist or the PCP. But we always reach out to the PCP as well, just because we want those PCPs to quarterback the care. So even if the pharmacist has a recommendation for a specialist, they will loop that PCP in to that recommendation so that PCP can still, help follow through if needed. So as far as communications go, I think I've done a lot of work on the prescriber side. I think the member side is pretty straightforward, but I've been involved in kind of the development and creation of maybe the fax templates of what goes out to the prescribers. So we want to make sure that the faxes, are written clearly and concisely. They deliver the message that we want them to deliver. So I do a lot of customization with CVS into what the content that goes into that fax. So that's something that I do. And part of my review and collaboration, with our nurse case managers and, our CVS pharmacists is how should these faxes look, and even the communication workflow. So what types of recommendations, is it okay for the pharmacist to fax versus call? A lot of times faxes are not an efficient way to communicate with the providers, and because of our model, would it be better for us to email the providers? Could we get their email addresses? So our nurse case managers actually collect email addresses for the PCPs. We send them over to the pharmacist, and they might email the PCP instead of sending a fax, because we have higher confidence that that's going to be a more effective mode of communication rather than just a fax that might get e-filed or kind of lost in the paper shuffle. They think it's just any other refill request coming in from the retail pharmacy and doesn't get the attention that it might deserve. So all of these things are things that kind of I, consider. I look at kind of what's going on with our communications. Do we need to change anything? For example, the post-fax for the telephonic outreach was something that we put in place based on feedback from the doctors and what we saw going on with the program. So when we first launched the program, the pharmacists were only doing telephonic outreach, and we weren't sending anything written. We felt that the clinical conversation was the best route to go. Then when I get a little bit down, I start talking about reporting. I looked at claims. I did claims analysis as far as outcomes, and I found that a very small percentage of the pharmacist's recommendations were actually being acted on by the prescribers. So we went back and we talked to some of the doctors and said, well, why are you guys not doing the things you say you're going to do when you talk to the pharmacist? And a lot of the feedback was just that, we forget, we're pulled out of a patient room, or we're talking to the pharmacist for 10 minutes on the phone in between seeing patients. We agree with them, or we consider their recommendations at the time of the conversation, but then we go back to seeing our other patients on our roster for the day, and to be honest, we just forget to follow up on what was discussed on the phone call. So we said, okay, now we want the pharmacist to, after they talk to you, we're going to send you a written summary by email or fax of everything that you guys talked about to help you remember and help you take action. So that's something that we didn't think of at first, but based on kind of analysis of the program, we had to pivot and say, how can we make this better? So that was something that, I did and, created, and so that's just kind of what me being the program director and having responsibility of this program might entail, is how can we continuously, query and improve what we're trying to do. So just to talk briefly about integration here, we have like a homegrown system for our member health record, and integration is actually really important. So all of our members' information is housed in a system that we call iCentric, and the pharmacists have access to this. But then the other thing that we did was we created a comprehensive medication review section within the system to input all the data from this review. And what this does is it gives the case managers, the nurses that are making these referrals, visibility into what's going on with the pharmacist review. The prescribers, all the doctors also have access to this information, so they can log in and view this information in addition to what we're already emailing and faxing them. But it just really helps that care coordination, particularly between the pharmacist, the nurse, and the member. So one of the things that I did is, I'm not going to go into details on this, but we have a lot of, details about the engagement. So just basic stuff is like, when did the pharmacist try to reach the member? Was it successful? Did they reach the physician? And then all that clinical information, which is at the bottom of this. We have this kind of drug table of what the patient was starting on, what the recommendation was, and we import the pharmacist's notes into our system. So I, had a lot of work in developing what this data would look like in our system. So that's another thing that I work a lot on, is IT-related stuff. So how are we going to take the information that's captured by the pharmacist and use that in our system? How should we display it? What's useful for our nurses? What kind of information do the nurses and doctors want to see? And kind of from that perspective, within constraints of what we can do from an IT capacity, but I'm very involved in the development and the integration of this data into our systems. And then my last slide is just talking about metrics. So, the development and oversight is one thing, but then having to report on it is another thing. So I'm very integral and involved in what metrics, first of all, what metrics are we going to report on? Why are we going to report on them, and how are we going to report on them? So I just bucketed a couple of things here for you. So I look very closely at what I would call operational metrics up here on the left top corner. So things like how many referrals are going in, how many referrals are completed, how many are canceled. We have an escalation process. So if the pharmacist can't reach a member prescriber, it goes back to the nurse to ask for help. Do we need a lot of these escalations, and how successful we are in that process? So that's kind of just daily tracking. We have goals as far as the number of referrals we want to reach on a monthly, on a yearly basis. So I track towards those goals. In addition, I look at engagement metrics. So how successful are we reaching our prescribers and our members? Do we have a greater success in reaching, PCPs versus specialists? And if we only have a 50%, member and success rate, member engagement rate, what can we do to improve that? So I work a lot of tracking those and trying to, of course, make sure that we're as successful as possible in reaching our prescribers and our members. What are some of the barriers to reaching them, and how can we overcome them? So, for example, we felt that, with some of our acute nurse referrals, we were not engaging the member at a very high rate. So we actually piloted a warm transfer process to CVS. So when the nurse case manager had the member on the phone and said, you know what, I think you'd be a great referral for our CMR program, they would warm transfer that member right over to the CVS to try to get that appointment scheduled for the pharmacist right away. So that way we kind of like capture that engagement with the member, which is really vital to having, success. So, a lot of different things, I track towards, and then again, we try to solution to how to improve them. In the purple box, looking at recommendation metrics. So, of course, you want to measure the output of the program, right? So what is the nature and type and number of recommendations identified? So I use these kind of as a surrogate measure for the program, especially looking at like the quality of referrals going in. So I would say if we have a lot of recommendations that the pharmacists are able to identify, to me that's an indicator that we're referring good members into the program. Because if you cannot identify issues or problems with a member's medications, then maybe you're not identifying the right people to put in the program because all their medications are appropriate and as they should be. So I really pay close attention to that, and again, tie that back to who are we referring in, what types of recommendations are we identifying, and linking that back to, again, like I said, are we identifying the right people? And then lastly, I think is the most, it's an important one. I think it's the hardest one for us in pharmacy is kind of the value. We're really, as a healthcare industry, driving towards more value-based care for our members and even for our prescribers. So there's always a question of what value does the pharmacist bring? And there's a lot of direct and indirect value associated with programs like this. Direct value from a pharmacy savings. So, and I'll tell you that's usually not the case with these type of programs. And I've done analysis on that usually pharmacy costs don't decrease. If anything, they might increase because you're closing gaps in care. You're increasing adherence. Even though occasionally you might get some discontinuation of an inappropriate med use or consolidation of therapy, it's usually not enough to really drive a pharmacy savings. So what we really try to show with this program is indirect value, right? So that might be things when I say here, estimated healthcare cost avoidance. So the goal is if you have patients on the right medications, you're better controlling their conditions, you're overall down the line decreasing medical cost because you may prevent a hospitalization, you may prevent some outpatient care, you get someone's A1C, blood pressure, cholesterol under control, all those downstream costs associated with uncontrolled chronic conditions, we could be influencing. So that's something that's much harder to measure, and we're kind of still working on that, and I think most programs struggled that. But one way we approach it is looking at what we call a pre and a post analysis. So we'll look at total medical cost for 6 to 12 months prior to a member being referred into our program, and then we'll look at those costs 6 to 12 months after they're referred into the program. And what we would expect is that the medical cost, overall medical costs, go down as a result of, the programs that we implement. And so that's something that I work very closely with our analytics team in developing the metrics, and for that we also look at some pharmacy measures. So we might look at medication possession ratios to see are we improving adherence. We also look at admission rates per 1,000, ER rates per 1,000, and certain like PMPM, what we call per member per month metrics as well. So I think that's all I have. Yep. So I think I went over the time I said I was going to go. I talked about 35 minutes. I'll pause there. If we still have time, are there questions, comments
Sure,
about
it
the
looks like we have
program, about
one
what I
question.
do?
The question is, how does the fragmented healthcare system affect your job and responsibilities, if at all?
You know, it's a good question. I think one thing that we do really well here at Care First is trying to keep that, you know, I don't want to say unfragment, but within our PCMH model, because we are charging that PCP for total care of the members that fall under them, we really, the fragmentation is less, you know, my program or CMR is less impacted by that fragmentation. There is still some when we get to specialists. So because we involve the PCP so heavily in our programs, particularly this one as well, the CMR program, we have problems when we try to engage our specialists because they're not aware of the program, they're not aware of our PCMH model. And then, you know, so one, we have difficulty reaching specialists, we have difficulty in them like buy in and accept our recommendations. And then when we discuss those with the PCP, we would still bring those forward to the PCP. We find that PCPs, even though we're making them responsible for 100% of the care, they're very reluctant to take action on anything that a specialist owns, right? So if a specialist started a medication and we say, you know, we know you're not the PCP, we say, we know you're not the prescriber of this, but we've identified this issue and here's our recommendation, they're going to say, well, I'm not touching that. That's the specialist. So that does impact our program and how successful we are in some of our recommendations. So we always try to come back to the PCP and say, well, you know what, you're part of our PCMH program, and as being part of that, we want you to be responsible for what the specialist is doing. But it's a harder mindset to get those PCPs to overcome. So I hope that answered the question.
All right. Well, thank you, Dr. Poplawski, and thank you, everyone else.
Great. Thank you, everybody. I hope you have a good rest of your day.